and thanks for having me. As you mentioned, I'm both a surgical registrar in London, and I'm also a clinical research fellow, and I spend a lot of time looking at trauma data. So I thought I'd just start a little bit about how I ended up doing what I do, and then specifically talking about the UK context when it comes to road traffic injury data, which is, I think, probably why Lauren asked me to talk to you, and then maybe how that sets everything up, both not just for me, but for all of you who are interested in RTI data and how we can use it to change things. And it's a really interesting time to be doing that. So I started my, I guess, medical and research life in between these times, I guess. So I was interested in global health when I was at medical school, and I went off and did an MSc and things. And back then, everyone was really talking, I wouldn't say almost exclusively, but certainly very heavily around HIV, TB, and malaria. That was the big thing. That was what everyone thought was going to be the thing that held countries back. It's what we needed to invest in, and it's certainly been killing a lot of people for the previous decades. But as I got more and more into my clinical life, I became very interested in trauma and injury, but in the global health context, nobody was really mentioning it almost at all. And whilst they made these massive strides in HIV, TB, and malaria, very little was being done with injury. And that was this kind of very interesting contrast, I guess. So for those three, the big three, I think they're referred to sometimes, there's been a lot of success, certainly since the 90s, when they became they were in the news a lot and people were thinking about them a lot. There's been big success stories with all three, dramatic drops in deaths and certainly infections across the board. And they still command a lot of research and intervention funding from a lot of global funds. But we don't see the same sort of thing in injury. So it's not just for road traffic injuries, it's for all injury, all trauma. And there's a lot of reasons that are not entirely rational, just very human, I suppose. So I think particularly off the back of the HIV pandemic in the 80s, there was huge calls for something to be done, a lot of high profile people asking for change, galvanizing a movement, I suppose, so strong advocacy. We didn't really have that in trauma. A lot of trauma is unintentional, and there's this idea if it's an accident, there's not much you can do to prevent this from a systems point of view, which is entirely untrue, but nonetheless, that was the prevailing view. And then we didn't get much funding because people weren't talking about it, weren't thinking about it. And then when it comes to actually putting in interventions for things like TB, HIV, and malaria, yes, they're challenging, but they've got very clear, relatively clean-cut things you can do. So vaccinations, medications. Okay, yes, there's challenges about getting these things to the right people at the right time, but nonetheless, nice sort of linear cause result relationships. We don't have that in trauma. We have very complex disease. It's very heterogeneous. All kinds of things can lead to injuries, and we can get all kinds of injuries off the back of that. Different parts of the body, different degrees of physiology, and our interventions really are more about systems. I mean, yes, there are individual things that can be done for different particular organ system problems, but nonetheless, it's trauma systems that we talk about as the mainstay of how to deal with them. So that's already a problem. And then when you come to the data, it's all of these things are kind of, it's the epitome of this is demonstrated in the data. There's nice, clear, robust surveillance metrics and data available for most infectious diseases, certainly the big three, but we have really struggled with this for injury over the past few decades. So that's kind of how things started out for me. And sort of slightly before my time, but I was able to read about it. The WHO eventually published some guidance on what should be done with regard to trauma care around, I think, the mid-2000s, something like that. And the first papers were all on pre-hospital care because so much of the disease patterns or the injury patterns and problems were happening in the pre-hospital setting. But they still talked about systems because obviously that's how you got to approach it. And people have gone on to say, oh, let's do a systematic review to see if trauma systems, pre-hospital systems, do they work in different healthcare contexts. So high income countries certainly have showed efficacy, but does it work in low and middle income countries? And it's not maybe the best way to approach it. I think you've had a previous speaker talk about why approaches like this maybe don't work when you've got a complex problem. And actually in that situation, it's all about the facilitators and the context and things, the mechanisms that can make something that clearly could work, definitely work. And at the same time, in the background, there was this idea, if you're going to have something as, complex and fancy as a trauma system, it was going to be expensive. And that's not actually necessarily the case, but this idea sort of made people think, well, it's just going to take time for countries to slowly build up their GDP, get economic growth, and slowly start to invest in health, and eventually it'll come, as it did for high-income countries. And I guess I was a little bit idealistic back then, and I thought, well, there's got to be a way that we can subvert that. Can we circumvent that sort of that waiting time, that evolution? Does it have to be that way? And I got taught something very interesting when I was studying global health, which is this thing called the Preston curve. There's some critics, but just it's a relatively simple concept in that you have this idea that the more money a country has, so often they use GDP as the metric there, the better the healthcare outcomes, and often it's life expectancy that you can see the charts for, but you can plot it against anything. And there's a curve to it. So a little bit of money goes a long way in the beginning and then eventually it evens out. And that's the general trend. But what's even more interesting is you've also got these countries that do disproportionately well or disproportionately poorly for what you'd expect them to do for their GDP, for how much money they've got to throw around. And classically, I think people talk about the US, they've got a huge GDP, but nonetheless, their healthcare outcomes are on a par with countries that have got a lot less money. You've also got the sort of the classic examples of how to do it well. So for a long time, people have talked about the Cuban healthcare system. They use Sri Lanka as an example, Kerala, which is actually not a country, obviously it's a state in India, but nonetheless they've done with their health problems very well. And there's certain things that these countries do, and it's just about the little money that they have, they spend it wisely. There's differences, but largely there's an emphasis on not just public health, but the wider determinants of health, so sanitation, education, all that sort of thing. And I guess I wanted to see, is there something that we could do for trauma systems? And I guess I started my junior surgical career around the time that the London trauma system was being rolled out. So that was around 2010. And this is the picture of that, but it's roughly got a northwest, northeast, southwest, southeast setup. But that wasn't really done on sort of any geospatial mapping. That was just kind of partly commission based. But nonetheless, the idea that pre-hospital's kind of really got to be where it starts. You've got to think about your distribution of your facilities and where your trauma is happening is an idea that actually does exist elsewhere. When they were planning the Scottish major trauma system, they've got a different population density to London, for example, and they're far more sparsely populated. They've got very hazardous weather conditions at different times of the year, or and they can't get helicopters to certain places at certain times. So you end up having to think a bit differently about where you're going to set up your stuff. And if we go back to that idea of how can you get your money to work harder for you, if you're going to say to whether it's a poorer country or a poorer region or a city or whatever, why don't we use what facilities you have? Why don't we leverage them as best we can? So what's the best model setup we can use for your facilities to get them to the people that need it the most of the time? And Jan Jansen did that work for Scotland, and I think there's been, around the late 2010s to 2015 to 2020, there's a lot more people doing this, and certainly in the States and for military work, this was a sort of a technique that was really taking off, and I thought, could we use it for some low middle income country contexts? So I got all excited about that, and then I found this problem. There is huge problems with the data. Largely speaking, it doesn't exist for a lot of the places that I wanted to do work in. Where it does exist, it's all over the place, just different places, not necessarily very accurate, just a total nightmare. So it's just broadly speaking, three categories just to think about. Coding what we describe as an injury. As we talked about before, we can describe it from its mechanism, we can describe it from its outcome. And it's not, again, like, do you have TB? Do you not have TB? It's, you know, that's a relatively clean cut definition that we don't have. You're not legally in most countries mandated to collect this data. It's nice. It's I guess there's guidance and standards that people try to adhere to, but you don't necessarily have to. And even where you do, and for example, we're supposed to be reporting in the UK, many of the public don't necessarily know that they have to, certainly for minor injuries. So we underreport, and when we do collect data, it is in different places. You've got it in high income countries. It generally tends to be the police and transport system collect the vast majority of it. And we have it in healthcare settings as well, but we don't necessarily collect it in a way that gets fed into a national system. We do in the UK and in some other countries, but that's certainly not universal. So this was a problem. So I ended up trying to make it a little bit simpler by moving away from injury as a whole to focusing on road traffic injuries. And that was just because, well, a couple of things really. One, when you're trying to model anything or do analysis of anything or do something, I guess, novel, you want something that's relatively stable, and then you can roll it out to things that are a bit more challenging. So I stayed away from conflict type stuff or interpersonal violence. There's a lot more social and political complexity to that. And road traffic injuries, for a long time, pretty much since we've been collecting injury data, well, I'd say probably the 1970s onwards, have always been a huge component of global injury. About 25%, the number varies a little bit over time, but roughly around there. And even though the proportion of road traffic injuries as a proportion of trauma has changed slightly in high income countries. So, for example, in the UK, it was our leading cause of trauma until about 2013 when falls in the elderly took over. So that's more, it's not so much that we have made some strides, but we've also got a changing demographic, and those things play into the overall picture. But nonetheless, for us, road traffic injury is still a significant concern. I'll tell you why a little bit later. I was still very perplexed by this whole thing. So we're 2020 now. This is just before the COVID pandemic broke out, and there was a leader in The Economist just stating still road traffic injuries are costing more lives than HIV and murder, and these things get way more press, way more money, way more attention, and still kind of perplexed as to why that was the case. Around, I guess, maybe a little bit earlier than that, and I think, again, you've had other speakers talk about this, but the WHO is finally started to work out, instead of just looking at community care and infectious disease and that sort of thing, which is obviously very important, but, you know, our story for people who are interested in injury, we've been largely neglected for a long time, but realizing that emergency care is inherently important for any health system to function well, and emergency care obviously doesn't just include us in injury. It's obviously all the heart attacks and sepsis and anything that needs timely intervention. And although there's this focus in saying, well, this is what it should look like, from a data collection and analysis point of view, for people who work in these fields, it presents additional challenges compared to, say, you're working in the community collecting data around TB. I mean, you go to the local practitioners or the local service, and again, the data collection is quite structured, and there's only certain places that you have to, you know, go register it or pick it up from. For us, you've got this problem, you know, pre-hospitally, you know, it's this perennial issue about how we do pre-hospital research. It's a fast-moving environment. The ethics are really difficult. You know, can't you collect data without permission? How do you do it? You know, and all of the time, if they're very, very unwell, you don't always know who these people are. They're anonymous. So that's a problem. It's rapidly evolving. So what's one set of data at the beginning, you know, a few minutes later could be a bit different again. We've got different services who are helping. So we've got ambulance, police. We have an NHS, but in many countries there's multiple different ambulance services, some of them private. And, you know, who's collecting what data? Is it brought together? And how do we define the mechanisms? What are we putting down on those forms? How are we recording the injuries? Do we record anatomy? Do we record physiology? If you're a traumatology person, so anyone working, you know, from the clinical side, for us, it's not just about, you know, it was a hip fracture or it was skull fracture, or, it's what's the physiology, how sick are they, is this thing going to kill them, is it going to kill them now, is it going to kill them later? So there's a lot of stuff that is in data that means something to one set of people that isn't necessarily relevant to a public health person, that isn't always in there. But if you're somebody who's interested in both, and you have to be ready for this to move on, we have to be collecting both. So yeah, it's a big problem, and it's hard enough collecting the data as it is, and then if you haven't got the money to fund it, it's even harder, which again just sort of adds insult to injury. That wasn't an intentional pun, it just came out, apologies. So where do we get the figures for global road traffic injuries? It's a lot of estimates, actually. So every few years, the WHO, since 2009 anyway, which is around the first time they really put a big stamp on putting road traffic injury out there as a big global concern. They've been publishing these reports. It has different, each member nation, each country sends off data to WHO, and they will try and turn it into national statistics. If you don't have enough, I guess raw data from your police and the health systems, then they will do usually a binomial regression to try and work out probably what your real rates of mortality are. They take different features into consideration: your total population, the vehicle numbers, particularly motorbikes, whether you're urban or rural, the road speeds, or at least what they're supposed to be, healthcare access, GDP, and even things like corruption and your sort of legislation around transport. And the models work great for some countries, and not so well for other countries. And obviously that's a limitation, but people are working within the confines that we have limited data. Nonetheless, it's a starting point and it's important. But what do we do to move on from here? Because it's back then it wasn't, but it's now 2026, and we certainly can and should be doing more. So I started going to all these conferences and hanging around with people who were interested in road safety, and this thing became very evident that I would, some days I'd be at a trauma conference with a lot of clinicians, and we would talk about, certain maybe injury groups, so cyclists maybe, or motorcyclists possibly, or whatever it might be, and talk about the outcomes. And then at the same time, these road safety conferences, most of them are run by transport people, people in engineering, police, that sort of thing. And they would talk about it from an infrastructure perspective, and a lot more about geospatial things, what kind of roads, and certainly there was crossover, what kind of vehicles are involved, demographics, and they were certainly interested in deaths as well. But just this sort of real feeling of, I was often in the room, if I was in a clinical conference, I felt like the only person who was interested in the wider sort of contexts and mechanisms and the road networks and the vehicles and all that sort of thing, and how that would lead to the outcomes. And if I was at a road safety conference with the police and transport guys, I would feel like the only person who thought that very specific things about outcomes were important. So kind of this feeling of siloed working was very, very clear. It's getting a little bit better, but we're still a long way away from what it could be. And so that ended up with me having to go into this. I didn't start off wanting to do this. My main research question when I began my PhD was actually looking at sort of slightly unusual data that you could leverage. I'll talk about that very briefly at the end, but to test that stuff out, you need to have your gold standard stuff, which is collected by the authorities, and generally speaking it's the police for the transport sector, and it will be somewhere between, if you've got pre-hospital systems, so potentially ambulance services, a lot of places don't, hospitals, possibly mortuaries, that sort of thing. And there's lots of reasons we do this, but like I said at the beginning, one of the biggest issues that we have is that we don't have A, complete data, and B, the quality of that data is slightly dubious. So some bits of it are good, some bits of it are, questionable and not necessarily accurate, actually. And if you want to start saying, well, this mechanism leads to this injury, and if you want to understand it like we understand many other diseases, if you take heart disease, for example, we know certain lifestyle factors lead to more risk of heart disease, and then we can target, whether it's medication or, exercise or whatever it is. Knowing that story in its entirety is what allows us to be, I guess, more cognizant about how to target it effectively and as a group of researchers and clinicians and just general individuals interested in making this situation better, it's really hard just only knowing half the picture. And I think without doing that, we can't really leverage people in government and in funding to give us the money to get on and do what we know can be done. So lots of different reasons to do it, but broadly speaking, that's the main one. And actually, not just WHO, but even in sort of the European region, I know we kind of left, but we still submit our data every 3 years or so. We're supposed to not just show our the collision numbers and which types of vehicles have been involved, but something called an AIS, which some of you will know about depending what kind of research you do, but there's injury scoring systems. All of them have got pros and cons, but AIS is probably one of the oldest. It's come from sort of the 70s, and it was between engineers and doctors, and it was public health bent to try and work out which groups or combinations of injury would give you a greater chance of death, essentially. So the higher AIS, the more likely you are to die, and there's a certain cutoff that they get interested in. And it's a very, very coarse yardstick is measuring serious injury versus minor injury from a public health perspective. So because this is all getting a little bit complicated, I obviously move away from trying to do this in a global health context where I've got very little data as it is, and it's going to be very challenging, and I wasn't willing to take it on trying to go around getting data from different people. So I brought it back to the UK because actually, if we can do it in the UK, maybe you can use that as a base to roll it out elsewhere. And as it turns out, there's issues in the UK. You probably know all these facts, you've probably seen them because they get bandied about quite a lot, but we still have a big problem with this. In the 70s, it was obviously a huge problem. Lots and lots of people were dying, and there was a little bit more effort to change the laws and seatbelts and alcohol and some of the other common public health interventions that we take for granted at the moment. But we've not made a huge amount of progress for the last 15, 16 years or so. And at the moment, we do still see a lot of people, in total numbers, maybe not as many as some of the other diseases that are leading causes. But within certain demographic groups, it is very high, children in particular. And we probably underappreciate what's going on because our stats are in different places and not joined up. And there's a lot of non-fatal, quote unquote, minor injuries, but these can still have, consequences for your quality of life in the long term. And if you take the total number of them, that kind of as a group, cumulatively is a huge cost, both in human terms and financial terms. And we don't really talk so much about the psychological component, but there certainly is that to think about too. And these costs, so if you think about what we, I say we, Department of Health and a lot of people in healthcare focus on, they are the leading causes of death. So we've got cancer, heart disease, and neurological stuff, so stroke. And the cost of those, this is an article from The Lancet, not that long ago, but the data is from 2018. And they look at the breakdown of those costs. So it could be the healthcare costs, but the ongoing social care costs, and the productivity loss. So you're sort of sitting around between 12 and 18 billion for each of these. Now, in the same time period, so 2018, DfT made the estimated, again, these are all estimates still, but they estimated the cost of road traffic collisions, and that's particularly the injuries. The property cost, i.e. the actual vehicle loss and road infrastructure, whatever, is minimal. So this is really road traffic injury cost is around 36 billion. So that's a huge, difference, but we still don't talk about it. Department of Health's got very little focus on this. We have been doing some work with them more recently, which is I'll mention it at the end, but the fact that we've got this slightly irrational focus on things that are certainly important, and a lot of people die from them, but the reason the cost of road traffic injury is so high is because it's people who are younger, it's people who are responsible for the household, it's often males, and poorer people. So the effect of them, either dying or not, being disabled over time, for the way we measure healthcare outcomes in economics is disability adjusted life years. It's basically the loss of good quality life years. That's huge. You get them when you're young, and you just, that knock-on effect both in human and financial terms, is big. For us in the UK, the cost to the GDP is about 1.4%. In low middle income countries, it can really range between 3 to 7%. I think the World Bank has published some figures on, and that for them, really stops them from progressing and developmental growth, which, again, they end up in a sort of a chicken and egg situation that you can't get out of. So investing in road traffic injury care and prevention is a really important way to think about improving development. Okay, so when we spend money in the UK, if we think about so just research, because that's all good, find the figures on, I couldn't find it on total intervention spending, but the figures for injury investment are really small, and I don't know if you can see the slide, apologies if it's a little bit small, but the orange, the bar chart on the left is just total funding. The different colors are different years since about 2004, I think. But injury is the one with the orange star, tiny amounts of money. And then you've got down at the bottom with the blue and the green stars, you've got strokes, cancers, and that sort of thing. And they just get so much more money. And then the chart on the right, that is the comparison. So the pink is what we spend, and the brown is the DALYs, the UK disability adjusted life years lost for that particular disease. So at the bottom, you've got cancer in the green again, and heart disease and stroke in the blue. And you can see, they're spending a lot of money, but the DALYs are quite high as well. But the amount of money you spend for the DALYs lost is relatively proportional. If you look at the injury situation up with the orange star, okay, yes, we have fewer injuries that are resulting in DALYs loss, but the amount that we spend proportionately is so low. It's disproportionately low. So it's a real problem, and you can kind of see it playing out with our progress on road traffic injuries in the past decade or so. We were a leading figure in the road safety world. So this is our progress since about the 70s. That's the larger chart on the left. And the UK, as well as Sweden, was held up as this sort of big example of how you do road safety right. It was a lot of the public health interventions I spoke about earlier. So, alcohol, seatbelts, speed limits, that sort of thing. But around 2010, we hit this kind of plateau. There's a little dip during COVID, as you'd expect, but really we bounced straight back up again. We have reduced, if you go to the smaller charts, we have reduced the total number of casualties, potentially. I'm not totally sure I believe it, but it's possible. And I'll tell you why I might not believe it in later slides, but the fatality rate, so fatalities I do believe a little bit more. The fatality rate certainly hasn't significantly altered. There's maybe a slow decline, but it's really not very much. And when you put this into the context of, there are huge efforts both in Europe and high income countries to follow something called Vision Zero, which is to try and reduce total fatalities and serious injuries on the roads to zero by 2030, that this level of progress is clearly not going to work for that target to be met. So this data is from, let me just, sorry, I think I've lost where I was. This data is from the Department of Transport. So most of the data that we use in the UK is based on something called Stats 19. Stats 19 is collected by the police and only the police. It doesn't have any healthcare input into the actual healthcare outcomes that are there. If there is a death, they will confirm with coroner or that sort of thing. But in terms of actual injuries, not really. So we've got this picture that the national statistics are based on this, all the policy papers are based on this, what the Department of Transport does is based on this. At the same time, we, especially if you work in trauma care, we know we've got a slightly different picture going on when we think about major trauma systems in the UK. I work in London, and that's been a real privilege to see, the major changes that have gone on in the past over a decade now. So it's been going on for longer than this, but the Major Trauma Network in London had its anniversary in 2020, I think. Yeah. And if you, even if you take out the the sort of COVID period. So in the first 5 years, they reduced their mortality rates by about 50%. Nationally, there was a reduction of about 20%. So, you've got, on the one hand, a plateau that you see in the police data, but on our side, we're showing, well, people that would have died haven't died. So probably, ostensibly, what you're seeing is that actually we haven't been winning in terms of road safety strategies and that sort of thing, but we have been doing, well, if you exclude healthcare, we have been doing better in post-collision response. And that joined up understanding is not there at higher levels of government at the moment. I think we're on the path to getting there, but without the two again talking to work out what's going on, it's hard to know. There is some work from TAN as was now an MTR, but they had started to slowly look at this, and it might just be that patients who probably would have died are no longer dying. We're keeping them alive, but without understanding who's doing what to change the outcomes, it's difficult for us to put more resources into A, investigating that further, and B, trying to emulate that in a way that brings total numbers down for real. So anyway, back to Stats 19. This is why, well, it's one of the reasons I have a bit of an issue with it. It's no secret. I work with the guys at DFT and they ask me questions about this every now and again, but it's the best they've got for the time being. The reason this is a problem, what this kind of figure shows, is this is how they describe injuries. Essentially, it's a scale that they use. It's relatively, if you're a clinician, it's relatively rudimentary. It's not actually a corollary, I think, for severity that is robust, but it's what they use to decide if somebody's got a serious injury or a slight injury. Obviously, if they've died, that's a black and white binary outcome, so it's a bit easier for them to tell. But the other things are quite grey, and asking a police person without extensive healthcare training to be able to decide what an injury is, I think, is really unfair. It's hard enough for clinicians to do it in the pre-hospital setting without all the diagnostics we have in hospital. Even then, sometimes we don't know what an injury is till we take them for a laparoscopy or operation and find it. You don't even see it on CT sometimes. So it's difficult. So the Stats 19 data is really limited in terms of the outcomes that it gives you. And without that, we don't really know so KSI is killed and seriously injured. So we don't really know what the KSI numbers truly are. They're probably underestimates. And we know from some previous linkage work that that's probably the case. And I've talked about these scoring systems that we've had. So some of you will know AIS, abbreviated injury score. There's plenty of others. ISS is related to that. There's many. And the reason we need them is that so we can compare one population with another. So it's good to have something that's standardized. But, they have a little bit of a problem in that you can have, a person who's very sick. I'll give you an example outside of road traffic injuries, but, stabbing to, the heart in theory can potentially be life-threatening. But when you score the injury, it's just the one injury in the one zone of the body. So the actual score compared to total trauma, if you had lots of small injuries, from a whatever else, it doesn't show you the full picture. There are other scores that look at physiology and they're very useful, but getting physiology data for this kind of thing is something we're trying to do, but as you can imagine, it's very difficult. So this is an ideal continuum that we'd like to talk about. It's everything from the pre-hospital setting when the collision happens, through to pre-hospital, bringing them to the hospital, the care that they get on that journey, what we do in hospital, ICU, rehab, back to society, and then it goes back round again. So 7 goes back round to 1, and then we're talking about public health interventions to prevent those things, and then the cycle goes on. And ideally, we want data describing all of that stuff. This is not new to you, I'm sure. It looks very similar to, I think, the chain of survival that Tim's proposed. But, we're all singing from the same hymn sheet. There is this a chronology of events that we know goes on. It happens very quickly. And for us, it's different people, different disciplines. And so getting us all to work together, even at least to collate the data, is a challenge. As I've said, most of the data that the UK uses to talk about road safety and the current progress is all from Stats 19, and that just covers these first 2 parts here. What we really want is this. We want the whole continuum. And actually, what's really great about the UK, and also very frustrating at the same time, is that we have these data sets. NHS Digital has data sets for ambulance care, for emergency department care, for admitted patients, for trauma patients. And we just need to join it all up. She says, like, it's an easy thing to do, and it hasn't been, but we have been trying. And the reason we want to do that is because everything we do to have good, effective road safety strategies is underpinned by good data. This idea of linking data together is slowly being picked up in other parts of the world. So Sweden have got their Strada systems, so they actually they do it in a slightly more labour-intensive way. They'll go and interview patients after the collision as well, and prospectively collect data in that way. New Zealand ran a project called Sorted a couple of years ago, which I think they plan to continue, where they more like what we're trying to do, so retrospective sort of existing data sets, marrying them together to get better insights. And politically speaking, it's not like there hasn't been a drive from the government to do something similar, not specifically for trauma care, but across all aspects of the government. That the data's kind of in secure government centres, and it's trying to get them linked together so that we can make more sense of what's happening to people, so we can help them out. There's some really good examples, but again, quite specific things. I think there's a group at UCL who've done a lot of work on child health, and a lot of us met up, and for all of us, it's taken, despite this, recommendation from government and for Office for National Statistics that we should be doing this sort of thing, the amount of ethics and legal loopholes you have to, not loopholes, but administrative form filling and things that you have to do is extensive. And for most of us, it's taken over 5 years, between 5 and 10 years, to try and get linkages sorted out. And the reasons for this is because there's multiple barriers. So you've got legislation, although we're not in Europe anymore, we still follow GDPR. It's not the wrong thing. GDPR has got a lot of strengths to it, but to navigate it when you're trying to link to get the data for people who haven't given their prospective consent for you to use their data, you kind of need some identifiable factors, otherwise you can't link very effectively. So you have to go and get special government permission. There is a process for that, but it's quite extensive, and you have to go and have a number of public engagement activities to demonstrate what you're doing, make sure there's no dissent, and have ongoing ability to talk with the public just to make sure there is ongoing support for your work. Then even when you get the data, you have to think about how to match it. There's no common identifier a lot of the time across all the data sets. Some of them do share an identifier. Sometimes it's incomplete, so we use a lot of other options. So fuzzy matching, there's a lot of machine learning that we're moving towards now as well. And then when it comes to the analysis, we're already seeing there's a difference between how healthcare people interpret the data that's put in front of them once it's linked versus the transport people, and we need to work together to be able to actually get the story straight about what's going on. So not to bore you with this, if you want to look it up, if you search my name, I wrote a policy report with the RAC Foundation a couple of years ago now, just saying how the UK should go about doing this, why we should be doing it, and the barriers to doing it. And what was kind of slightly unexpected but really welcome was there was a lot of, support that it got from Department of Health, Department for Transport certainly been particularly supportive of the work, and various other stakeholders, both in academia and in policy. So we had a round table to try and look at how this might come about. I'll just skip over this next slide because it's just the advantage of linking data nationally, which I've kind of mentioned over the course of the talk already. But we had a group meeting, a national round table with all the stakeholders, and there's certain ways, if you're going to do this properly and you want to do it right, because it's hard. Like I said, it's taken me several years to get it underway, and a couple of other people have had similar projects that have taken a long period of time, and even then it's very difficult to sustain it on your own. So if you do it right, it should be something that is sort of set up and can continue to run in an ongoing way, because all your permissions and data flows are sorted really. So you need to have the right data sets. You need to make sure you're compliant with all the legalities. You've got to do all this public engagement work. And you want to really, and this is, I guess, where, you know, there's relevance for you and the audience, you want to make it accessible to the people who can actually take the research, take the data and turn it into meaningful research that can be turned into actionable outcomes. And so the idea is that once some of us have done all this sort of heavy, you know, ethical, legal and logistical heavy lifting, that the rest of you guys don't have to replicate all that ad infinitum. You can just get on and do some research with it. And, you know, what's also good about democratizing that data is that you can look at what's locally relevant for you. You know, the picture that's going on in Scotland, for example, may not be relevant for somebody who's working in London. You want to be doing something that's locally contextually useful, as well as obviously the national outcomes. So when we got around the table, we agreed that that's kind of what would be the gold standard hallmarks that we wanted to have. And we came out with these sort of outcomes, I suppose. It's a joint agreement between different governmental departments, the Department of Health, Department of Transport, and a number of other institutions that we would support this, which means that it's easier for the people who are trying to, the data controllers often get very funny about giving this data out because of the ethics of it. So they've got the go ahead. And then we started building a pilot. The pilot is part of something called Prana, which you may or may not know about. It's under the auspices of Phil Hyde, who works down in Wessex. He set up this, it's a registry that brings together data primarily for a pre-hospital cause, but one subset of that project is Data Sustains Lives, which is specifically for road traffic collisions and injuries. And there's lots of different data sets that we've taken. He started off really by looking in southwest England because that's where he's based and he had access to data controllers there. But we've finally managed, well, he and the team, certainly, I sit on the sort of advisory group, but luckily the heavy lifting is come away from my hands, and they finally managed to get the agreements in place, which still took a long period of time. But then the data sets are now, I think, have arrived, and preliminary analysis happened just on linkage. I think last autumn there was some stuff done just on southwest data between ambulance and police stuff. We already know some things that I kind of suspected from my work, which is the linkage rates are still a little bit low in that there's an overlap between police data and what we see in pre-hospital, but there are actually also lots of people who are in one data set but not in the other. And there's a difficulty interpreting what it means in terms of clinical outcomes. So that's the next step of what's going to be happening. Luckily for us, there's still an appetite for this. The Department of Transport announced their road safety strategy for the upcoming years, and the Data Sustains Lives project was part of how they really want to take this on. So ideally, this is going to be something that we do on a national level, and it's going to be part of ongoing road traffic injury surveillance for the nation. So that, I'm hoping, is going to lead to us joining up in terms of systems thinking, in terms of interventions between the police, transport sector and ourselves, and hopefully further funding, because again, this disparity between the resources that we're allocated and other healthcare needs is disparate, and it needs to change. So just very briefly going back to the global picture, this is still a problem. We haven't really made great strides. Since 2010 to 2020, there was a decade of action to try and halve the mortality or projected mortality. Didn't really happen too much. It didn't go up, but it didn't massively go down. So they've extended it to be another decade for action on road safety for 2021 to 2030. So far, it's still on a bit of a plateau. So there's lots that could be done. We need more money, and if we're basically going to make any sort of impact, we have to be aware that actually, as more countries get more and more developed, they have more vehicles and there's more speeds, and essentially we're probably seeing the epidemic is going to continue to grow before it gets better. So it's just whether we can, this idea of leapfrogging is whether we can mitigate that and stop it getting as bad as it potentially could be. My current work, just super brief, is if we can leverage the stuff that we have now in 2026 that they didn't have, you know, whatever, 50 years ago. A lot of that is to do with data connectivity, so digital data, internet connections, social media, other ways that we track different health problems. Can we use those instead? So I've been looking at a bunch of these in London and in South Africa, but that's a story for another time. But yeah, that's me. Thanks for your time, and let me know if you've got any questions.